Hey everyone, if you're a radiology resident looking to absolutely crush your upcoming core exams, you are in exactly the right place. I'm stepping in as your virtual radiology mentor today, and this explainer is going to be your ultimate high-yield review blueprint focused on one of those classic must-know board topics, gastric volvulus. We're going to cut right through the noise, look at the exact radiological images you need to recognize, and hammer home those specific buzzwords examiners absolutely love to test. All right, it's time to get you ready for the reading room and the hot seat. Let's dive in.
Okay, let's dive into this. Imagine you're on call. The ER doc pages you about a patient who literally just rolled in. They're presenting with severe, sudden epigastric pain. They are violently retching, but nothing is coming up. Absolutely no vomitus. And to make matters worse, the ER team has tried repeatedly, but they just cannot pass a nasogastric tube. So what's your primary diagnosis here? Take a second and lock it in.
If you guessed gastric volvulus, boom, you are spot on. What we just described is the classic bore chart triad. And let me tell you, this is a big one. This triad consists of three very distinct clinical signs. Number one, the inability to pass an NGT. Number two, severe epigastric pain. And number three, retching without vomiting. If you ever see this exact combination pop up in a clinical vignette, your brain should immediately flash straight to gastric volvulus. These three signs are the ultimate buzzwords examiners are hunting for to see if you actually understand the mechanical obstruction happening in the patient's stomach. All right, moving on to section 1, the two flavors, organoaxial versus mesenteroaxial. So gastric volvulus is basically the twisting of the stomach between its normal points of anatomical fixation. But for the boards, you've got to know that this twisting comes in exactly two distinct flavors. We have organoaxial and mesenteroaxial volvulus, and they are defined entirely by their axis of rotation. With an organoaxial volvulus, the stomach rotates along its long axis. That's the imaginary line drawn straight between the cardia and the pylorus. Think of the stomach folding up on itself lengthwise, kind of like a hot dog bun. Conversely, a mesenteroaxial volvulus features a rotation around the short axis. This means it twists perpendicularly right over its mesenteric attachments. Getting a solid grasp on this geometry is absolutely key to understanding how they're going to show up on your scans. Now, to keep these straight in your head, I've got a punchy little memory hook for you straight from the best high-yield review sources. Just remember, O for older. Organoaxial volvulus is by far the most common type, and it's classically seen in older ladies who have large sliding or paraesophageal hiatus hernias. So when you see an elderly patient with a massive hiatus hernia on a film and the stomach looks like it's doing gymnastics up there, you're almost certainly looking at an organoaxial volvulus. Keep that O for older trick in your back pocket for sure.
And this brilliantly illustrates the real differences between the two. Comparing them side by side, the organoaxial type rotates on that long axis, is heavily associated with older adults, and thankfully, major complications like ischemia are actually quite rare. On the flip side, the mesenteroaxial type rotates on the short axis, is seen much more commonly in kids, and, this is critical, is highly prone to causing serious ischemia and gastric outlet obstruction. Memorizing this contrast is pretty much your perfect cheat sheet for figuring out the clinical stakes of each type.
Okay, section 2, imaging the volvulus. Let's talk about what you'll actually see. Pivoting away from the clinical theory to the absolute bread and butter of radiology, we really need to focus on the specific imaging findings you have to spot on your monitors. First up is the plain abdominal radiograph. If you've got a patient standing for an erect XR, keep your eyes peeled for a very, very specific finding, a double air fluid level of the stomach. Because the stomach has violently twisted and folded, gas and fluid end up getting trapped in two distinct pockets. And honestly, this double air fluid level will often be hiding really high up, either in the upper abdomen or sometimes even projected right over the mediastinum if the patient has that giant paraesophageal hernia we just talked about. Now let's move over to contrast studies. Notice the distinct appearances here on the barium swallow. With the organoaxial type, the stomach folds upward and to the right. This causes the greater curvature to literally flip over and lie above the lesser curvature. But with the mesenteroaxial type, because that rotation happens around the short axis, it gives you an entirely different look. It's just a completely flipped, totally upside-down appearance. Now, what's really interesting about this slide is that upside-down appearance. Pay close attention to the anatomic relationships happening here. This is the absolute classic textbook look of a mesenteroaxial volvulus. Look at exactly where the distal antrum and the pylorus are positioned. They are quite literally sitting cranial to or above the fundus in the proximal stomach. Because of all this excessive mobility and twisting, the stomach very often kinks right between the body and the antrum, and that creates a highly dangerous site of obstruction.
The absolutely crucial takeaway here is that you cannot afford to miss a mesenteroaxial volvulus. Because the stomach is rotating around its mesenteric attachments, the blood supply is incredibly vulnerable to just getting pinched right off. This makes it a true life or death surgical emergency. It causes profound gastric outlet obstruction and super rapid ischemia. Oh, and as a quick added high-yield trivia fact for the boards, if you ever see an adult present with this type, always check their history for a traumatic diaphragmatic rupture, because they are occasionally associated. All right, let's lock this all in for your core exams. Here is a rapid-fire summary of the board-relevant mnemonics and buzzwords you absolutely need to walk away with today. First, memorize the board chart triad: no NGT, severe pain, retching without vomit. Second, remember O for older to link the organoaxial volvulus with a long axis and elderly patients with hernias. Third, know that mesenteroaxial means the short axis, an upside-down stomach, and a massive risk of ischemia. And finally, on an erect plain film, always hunt for that double air fluid level. Make sure you keep these facts locked in your mind for your exams and, of course, for your next on-call shift. Well, congratulations, you have officially mastered the high-yield points of gastric volvulus. But before we wrap up, I want to leave you with a provocative question just to test your diagnostic reflexes a bit. You know the stomach now, but what happens when a pediatric patient presents with bilious vomiting, and when you do an upper GI series, you see a classic corkscrew pattern of the duodenum? Think about what happens when the midgut fails to fixate properly during development. We are going to be diving into malrotation and midgut volvulus in our next high-yield radiology deep dive explainer. So stay curious, keep studying, and I will see you in the reading room.